Hello friends. Today we are going to discuss about high flow nasal cannula. This was the question which was asked in DRNB critical care exam in December 2022. So the purpose of respiratory support is to maintain the adequate ventilation and oxygenation. In this, ensuring the adequate alveolar ventilation is essential for expelling carbon dioxide produced in the human body. Because of the poor mass tolerance, however, NIV is sometimes inapplicable. So, high flow nasal cannula oxygen delivery has been gaining attention as an alternative means of respiratory support for critically ill patients. So, why high flow nasal cannula? Administration of supplemental oxygen has been the first line therapy for hypoxemic patients. So, oxygen is generally provided via face mask and nasal cannula. There are several drawbacks are associated with this device, which may limit the efficacy and tolerance of oxygen delivery. So usually the oxygen is not humidified at low flow and complaints, especially dry nose, dry mouth, dry throat and nasal pain are common. Bubble humidifier are commonly used for humidifying air delivered to spontaneous nasal breathing. But when absolute humidity is low, patient is still complaining of discomfort. So insufficient heating and humidification leads to poor tolerance to oxygen therapy. So using conventional device, oxygen flow is limited to no more than 15 liter per. Meanwhile, the inspiratory flow of the patient with respiratory failure varies in range from 30 to more than 100 liter per minute. The difference between patients' inspiratory flow and delivered flow is large. As a result, FiO2 is FiO2 is FiO2 FiO2 is constant in both and offer lower than the expected. So, as an alternative to uh, conventional oxygen delivery for hypoxemic patients, high flow nasal cannula oxygen therapy has been receiving more and more attention. So, let's talk about high flow nasal cannula apparatus. So, this apparatus comprises of air and oxygen blender, an active heated humidifier, a single heated circuit, and nasal cannula. At air and oxygen blender, the inspiratory fraction of the O2 is set from 0.21 to 1 in the flow of up to 60 liter per minute. So the gas is heated and humidified with active humidifier and delivered through the heated circuit. Another major difference between NIV and high flow nasal cannula is interface. While interface for NIV increases anatomical dead space, those for high flow nasal cannula actually decreases dead space. Since neither inspiratory push nor expiratory pull is effective in such a open circuit, high flow nasal cannula cannot actively enhance tidal volume. Even so, it helps COPD patient mainly by decreasing anatomical dead space, secondary by improving alveolar ventilation. So this is the pictorial representation of high flow nasal cannula, which consists of air oxygen blender, active humidifier, and it is delivering to the patient. It is delivering to the patient via interface, which is known as nasal cannula. So let's talk about the physiological effect. So gas from oxygen blender that can generate a total flow of up to 60 liter per minute is heated and humidified with active humidifier and subsequently delivered through the heated circuit. So high flow of activated heated and humidifier gas is considered to have number of physiological effects. So this high flow will wash out carbon dioxide in anatomical dead space. Although delivered through an open system, high flow overcomes resistance against expiratory flow and creates positive nasopharyngeal pressure. While pressure is relatively low compared to the closed system, it is considered adequate to increase lung volume and to recruit collapse alveoli. The difference between inspiratory flow of the patient and delivered flow is small, so FiO2 remains relatively constant. Because gas is generally warm to 37 degrees Celsius and completely humidified, mucociliary function remains good and little discomfort is reported. Now, anatomical space wash. Thoracoabdominal synchrony is better with high flow nasal cannula than with face mask delivery. Breathing frequency is lower with high flow nasal cannula, while PaCO2 and tidal volume remains constant. Since tidal volume is constant and breathing frequency is reduced, minute ventilation is lower. It is also like that alveolar ventilation along with PCO2 is constant. This evidence suggests that there is less dead space. Now, the next effect is effective CO2 washout. So, FiO2 was higher with the mouth open breathing. This may have been due to reservoir function of the nose, the pharynx, and potentially oral cavity. By allowing oxygen to completely suffuse the nasal cavity during exhalation, breathing with the mouth open may enable more efficient CO2 washout and provide larger anatomical reservoir. So, with inhalation, nasal oxygen is entrained and contributes to higher effect. Now, the next physiological effect is peak effect. Although a high flow nasal cannula is open system, high flow from nasal cannula prevails against the some of the resistance of expiratory flow and increases airway pressure. So, end expiratory lung volume was greater with high flow nasal cannula than with the low flow oxygen therapy. Now, the fraction of inspired open. FiO2 was higher during mouth open breathing and during mouth closed breathing. Regarding humidification in clinical setting, there are situations in which air moisture is reduced. For example, when a gas such as pipe oxygen is delivered from artificial flow source, or when endotracheal or tracheostomy tube bypass the upper airway, where most humidification would occur naturally. Conventional oxygen delivering dry and unwarmed gas are associated with mass discomfort, nasal dryness, oral dryness, and eye irritation, nasal and eye trauma, and gastric distension and aspiration. So, the conditioning of the gas minimizes the air constriction and reduces the work of breathing. Furthermore, the conditioned gas improves the mucociliary function, facilitates the clearance of secretion, and is associated with less atelectasis, resulting in the good ventilation perfusion ratio and better oxygenation. In other words, conditioning gases results in more effective delivery of oxygen to the lung. It can be particularly important for patients with secretion problem, such as those with COPD. An IV delivers medical gas at high flow. If these gases are inadequately humidified, oral dryness and patient discomfort are likely. So, the absolute humidity of the gas delivered through oronasal mask during NIV is affected by humidifier setting, and the amount of leakage varied among patients at equivalent humidifier setting. Since high flow nasal cannula deliver medical gas up to 60 liter per minute flow, inadequate humidification may cause same untoward effect as NIV. So provision of essential humidity through the high flow nasal cannula can prevent drying of the airway, avoiding inflammatory response caused by drying of the mucosa. Then hypercapnic respiratory failure. Hypercapnic respiratory failure is frequently encountered problem. Because of the poor mass tolerance, NIV is inapplicable to some patients. The successful use of the high flow nasal cannula oxygen therapy to manage hypercapnic respiratory failure of the patient who are unable to tolerate conventional NIV. Hypoxemic respiratory failure. Maintaining adequate oxygenation depends on properly managing FiO2 and P. So oxygen is generally provided via face mask and nasal cannula, and oxygen delivery is limited to no more than 50 liter per minute. So oxygen flow of 15 liter per minute via face mask was changed to high flow nasal cannula of 40 liter per minute. So under high flow nasal cannula, breathing frequency decreases and oxygenation improves. Now let's have a look on the Florali trial, which was published in 4th June 2015 in NEG. So the conclusion of this trial in patient with the non-hypercapnic acute hypoxemic respiratory failure, treatment with high flow nasal cannula, standard oxygen or NIV did not result in significant different intubation rate, but there was significant difference in favor of high flow nasal and high flow oxygen in 90-day mortality. Then Florali 2 was published. So conclusion of this trial was in patient with acute hypoxemic respiratory failure, pre-oxygenation with NIV or nasal cannula did not change the risk of severe hypoxia. Now the post-extubation. Reintubation is associated with increased ICU and hospital length of stay and mortality. So high flow nasal cannula seems to reduce the need of NIV, non-invasive positive pressure ventilation and reintubation. The PaO2 FiO2 ratio was higher with high flow nasal cannula than with Venturi mask. So with high flow nasal cannula, fewer patients required non-invasive positive pressure ventilation and reintubation. So oxygen therapy was started after extubation and continued to day 2. No difference in oxygenation was found between the group and PaCO2 was lowered in high flow nasal cannula at 4 hours post extubation and next month. For the kind of rigorous evidence we need to confidently guide clinical choices, we await the finding of OPERA trial, which is evaluating how well high flow nasal cannula prevents post extubation hypoxemia after abdominal surgery. Now, the next use is in the pre-intubation oxygenation. Intubation in ICU is often performed for hypoxemic and unstable patient and is associated with the significant complication. So before tracheal intubation to enhance oxygenation, NIV can be applied. If it is when mask has to be removed during laryngoscopy, the patient is deprived of oxygen during the procedure. So because nasal cannula do not interfere with the laryngoscopy, high flow nasal cannula could be used to deliver oxygen during apneic period of tracheal intubation. So the author concluded that high flow nasal cannula significantly reduce the prevalence of severe hypoxemia, and and its use could prevent the patient safety during intubation in ICU. Now it is also used in the condition like sleep apnea. Obstructive sleep apnea is attributed to upper airway collapse and is associated with intermittent hypoxemia, neurocognitive dysfunction, and cardiovascular morbidity. So the treatment of sleep apnea includes medical and surgical options. While CPAP is most effective treatment, adherence is suboptimal and large number of patients are left untreated. So high flow nasal cannula delivery for obstructive sleep apnea elevates the upper airway obstruction. And high flow nasal cannula also reduces the arousal and apnea hypopnea index in adult. So disordered breathing during sleep is also common patient and is associated with neurological worsening and poor outcome. Although CPAP is effective in treating sleep disorder breathing with stroke patient, it is often abandoned owing to patient discomfort. It has been reported that high flow nasal cannula was well tolerated and decreased hypopnea index and oxygen desaturation index. Now, this high flow nasal cannula is also used in the patient with acute heart failure. Now, regarding contraindication, if there are consciousness disorder like no response, agitated, uncooperative, then the HFNC is contraindicated. Then claustrophobia and airway obstruction, facial injury, facial malformation, a lot of sputum and risk of aspiration. Then in case of unstable hemodynamics like shock, intractable arrhythmia, and post-CPR cardiac arrest, HFNC is contraindicated. The causes of refractory hypoxia in ARDS is pneumothorax, systemic vasodilator enhancing shunt, pulmonary embolism, intracardiac shunt, and circulatory collapse. Thank you, guys.